So very good afternoon. I hope you had a good lunch and the talk on sexuality really woke us up. I'm going to be talking about the psychological aspects in patient care. Initially, I decided to do it like a discussion rather than a presentation, but I think for so many people it's easier to just talk about it. If you look at oncology, it is interdisciplinary, it is multidisciplinary. It's not just the doctors who are working, but it's a interplay of different specialists. And one of the reasons why they've included mental health professionals in the treatment team is because of the psychological consequences of a diagnosis of cancer. And they realize that these consequences are multifactorial and they're unpleasant. Because they affect cognitive, behavioral, emotional, social, spiritual, and also physical. All of this interferes in coping effectively with cancer, with its symptoms and its treatment. So we have two patients, same diagnosis, same age. One is doing very well, the other one is not doing well. And if you compare the two, you'll find that there's a difference in the way they cope with distress, or they cope with the negative aspects of cancer. In a study that was done in a small hospital in Punjab, they found that 90% of their patients showed some sort of depression. 56% of the patients showed anxiety, and 28% were what we call distressed or stress. So what is the spectrum of patient problems? It's physical, which we've been hearing for quite some time now. It's emotional, and it's affecting the family and relationships. It's spiritual as well as existential. Why am I here? What is my purpose? We had a young boy who, when he was given his diagnosis, he decided that, okay, what's the purpose of my life? What am I here for? And he actually stood at the crossroad for close to 24 hours, just watching the traffic going by, just to try and figure out what is my place in this world today. So who is more likely? So if you look at the distribution of mental health issues, the highest is fears, then comes anxiety, depression, adjustment, post-traumatic stress disorder, as well as what we call cognitive problems. So who is more likely to experience? Not everybody has what we call psychological distress, but who is more likely? People, it depends on the disease, the kind of illness, the stage of the disease, the prognosis, the treatment modality, inadequate treatment of physical symptoms, as well as sometimes substance use. We had a case of a patient who suddenly became very aggressive, very violent, and when she was sent for evaluation, we realized that she had DEXA-induced psychosis. So the moment the DEXA stopped, her psychosis reversed back. People with certain kinds of personality, that's including the age, the breadwinners in that age group are more likely to have distress. Gender, women are more likely to have psychological distress. People with poor coping mechanisms, if there is an existing family conflict, or the mother of all, financial issues. So why is mental health not addressed? One is, it's not strong enough for the medical professionals. They don't look at it as a part of affecting the consequence of the treatment. So it's the health professionals, it's their attitude towards mental health, their core belief, the lack of information about mental health, and the lack of a mental health resource. For patients, even now, there is a stigma related to psychological health as well as seeking psychological help. There's lack of information again, as well as there is non-availability of a counselor or a mental health professional. What is distress? It's an unpleasant emotional experience of a psychological, social, or a spiritual nature, which extends on a continuum from a normal feeling to severe distress. So all of us, at some point of the time, we have felt some sort of distress, mild to moderate to severe. So not all of us need to seek help, but if we acknowledge the continuum of where we are, then it is easier to seek help. So it's a feeling. Distress is a feeling, and these are all the feelings that you can. So let's look at anxiety. Um, it has a physical manifestation, it has a cognitive manifestation, and it has a psychological manifestation also. So when you're anxious, there's trembling, there's butterflies in the stomach, there is headaches, there is numbness, sleep. There's a feeling of you're not in control. There's a change in the breathing, there's a racing pulse, and there is a cognitive effect that I can't do it. It's too difficult for me. Fear, what are the different kinds of fear that patients face? Fear of dying or suffering, fear of disfigurement, which affects everything, fear of the treatment itself. Most of the time, mental health professionals are called in because patients refuse treatment. And sometimes it's just that big, long 11-letter word communication that helps to calm the patient down and to accrue to treatment. Fear of recurrence and a fear of loss of control. Depression. Depression is, currently India is highest. We are increasing in our numbers of depression, not only in oncology, but generally. If you look at PhD students who are studying pure sciences, 1/3 of all PhD students are likely to get some sort of depression in the 5 years or the 6 years of their PhD. So by and large, depression is really gaining momentum in India. It's a persistent feeling of sadness that interferes with daily activities. Now, what happens in an oncology setup? Depression is sometimes misrepresented by fatigue because its symptoms are so similar. So sometimes a patient may come to the oncologist complaining of fatigue, but it may be masked. It could be depression. So how do you recognize it? It's a loss of pleasure or interest in most activities, feeling of, again, nervousness, restlessness, tiredness, a change in the eating habits and sleeping habits, cognitively, feeling of guilt, worthlessness, and hopelessness. There's difficulty in concentrations as well as making decisions. Often there are thoughts of suicide or hurting oneself or others. We had a young woman who had 2 kids. One was just about 1.5-year-old and one was 5. And she had breast cancer, and it came back within 1.5 years. And she gave a distress call. She was in the bathroom. She had filled the tub of water, and she had taken both the kids in. And there was not only this feeling that I don't want to go through it, but I don't want my kids to go through that shame of not having a mother around. Luckily, she made the call, and we were able to reverse her thinking. There's an adjustment, emotional reactions to situations or stressors. There's an impairment in both social as well as occupational functioning. We've heard of cases where women do not even leave the confines of their home because they don't want anybody else to know that they are cancer patients, because they don't have hair, the loss of hair. So there is a social withdrawal, isolation, and many times women also choose, and especially if you notice, I've used the word woman more, because women, unfortunately, yes, we do experience more psychological distress. Post-traumatic stress disorder is a time lag. It's a psychological distress that happens after an event. So every time a woman or a man goes for their yearly screening, there is this impending doom, anxiety, heightened fear, which is real because basically they're reliving the cancer experiences. A lot of our patients do experience nightmares, flashbacks. They avoid places, events, or people associated with disease. That's why when we were talking in the break, and somebody said, why don't survivors come to a more pleasant place for their follow-ups so they are not hit with this constant reminder that they had cancer, but for a lot of reasons it's not possible. Being continuously overexcited, fearful, irritable, and unable to sleep. Cognitive disorders. We have a conference, an annual breast cancer survivors conference, And it was only 3 or 4 years back when we decided to include cognitive disorders and talk about it, because a lot of patients were complaining that they couldn't focus, they couldn't concentrate, they weren't able to remember smallest things like where did they keep their keys. We had a young girl who was working in an IT firm. She was handling calls, I think it's called a call center, and she says, I couldn't remember, I would take the call and I couldn't remember what I had spoken just about 10 seconds behind. So she had to actually record each conversation. So it was a problem and we weren't addressing it. So people with cognitive problems have problems with attention, thinking, awareness, emotions, memory, sleeping, waking, and muscle control. So how do I manage this? First is I have to recognize it. Many of us fail to recognize depression, anxiety, because we're not aware of it. Then how do I manage it? There are medicines, there are prescriptions, there are social and mental health services available, so we have to interlink with each other. When many of our patients do believe in complementary and alternative medicines, there is no harm in sending them over there because they believe that it will help. Spiritual resources, we are a country where spirituality is quite firm. It does help. Physical exercise as well as self-help resources, especially support groups. Specifically, specific support groups really help rather than just a general support group. One of the other things that is neglected a lot is caregivers. Everybody is focused on the patient, and sometimes the caregivers just gets lost. So we need to recognize it. Even though our interaction as a doctor or as a professional is only with the patient is not only the patient, it's a patient with the whole family. So who is more likely as a caregiver to have distress? One, if their loved one is in an advanced stage of disease, if there is disability, if there are complex needs. We had a patient who was young, breast cancer. They had only one son. The son was cerebral palsy. Resources limited. You can imagine the amount of distress the caregiver, the father or the husband had to face because he had two situations to deal with. Also, there will be spurts of distress, especially just at the moment of diagnosis, during hospitalizations, during surgeries, when a new treatment begins, and if there is a recurrence. So what can you do as professionals? A, talk about it. Provide information and education about treatment and procedures. So I'm a counselor, I'm a psychologist, I'm a clinical psychologist, and very often a lot of questions, they come to me. They don't come to the doctor because it's kind of a fear that patients face or they have a kind of a forgetting. They forget the questions when they're facing their oncologist. So they're directed either to the nurses or to the mental health professional. So what can you as a medical oncologist, a surgical oncologist, or radiation oncologist do is to provide a comprehensive information about the treatment and the procedures. Provide information about the common physical symptoms related to treatment. Very often patients come back and tell us, oh, लेकिन doctor ने बोला कि कुछ side effects ज़्यादा नहीं होगा. So sometimes we mislead, meaning well. It's not that doctors don't mean well, but patients have what we call selective listening. They listen to the good parts, what you want to say, and what is actually what you want to say is just kind of not heard. Monitor for distressing symptoms and recommend and refer to appropriate persons. So what can we do? A, acknowledge distress, recognize distress, and talk about it, communicate about distress. Thank you.